The lesson today is regarding urinary tract infections. When you have a patient who's coming in for a urinary complaint, make sure that you have the CNA or PCT collect the urine sample prior to the patient being roomed. This helps save time so that you don't have to have them be roomed, then go back to the bathroom, give the sample, then run through the urinalysis, and all of that. If the patient's been taking azo, the urine is orange, so it cannot be run in the urinalysis. It'll have to be sent to culture only, so you have to decide if you still want to treat the patient with an antibiotic prophylactically until the urine culture comes back based on their symptoms at the office visit. If it's a young male patient presenting with UTI symptoms like burning or discharge or blood that they see, always suspect that they have chlamydia or gonorrhea instead of a urinary tract infection. And I would collect a urinalysis, but don't let them wipe with the cleansing wipe on the urethra because it can disrupt the sample and be inaccurate. And what they are presenting for at the office visit. So you can ask them questions like, when did their symptoms first start? If they've had a fever, burning, frequency, urgency, blood. Vaginal discharge, vaginal itching or irritation. You can also change this up for a male saying penile discharge, penile itching or irritation. Any back pain, and you can ask them to be more specific in showing you where the location of the pain is, whether it's flank pain or low back pain, as that makes a difference, whether or not you're thinking of pyelonephritis or just simple urinary tract infection. Nausea and vomiting are also symptoms that are concerning for pyelonephritis, so you want to ask that. And any rashes, of course, that they have in their genital area. Of course, any medications that they've tried to treat the symptoms, whether it's cranberry tablets, cranberry juice, azo, Tylenol, ibuprofen, you can kind of ask that. And then the last few questions are in regards to if they've had a history of frequent urinary tract infections, because this can make a difference in how you want to treat them and what your next steps are. History of kidney stones, especially in males. You want to see if they do have blood in their urinalysis, that you make sure that their symptoms aren't associated with some sort of kidney stone versus urinary tract infection. And then, of course, if they have any history of kidney infections, those are going to be red flag symptoms. If they're having flank pain, that they have another bout of pyelonephritis, and you want to keep them from having to be hospitalized for that. And then as you see down below, the review of systems, you can ask, if they have any of these concerns. Typically, I run through this really quickly with patients. Fever, chills, trouble breathing, chest pains, abdominal pain, headaches, dizziness, passing out, rashes, moles, etc. Then you go through the objectives. So you, of course, review their vital signs. That includes their temperature, their blood pressure, and their pulse. Certainly, if they have been running fevers and have these sort of urinary tract infection symptoms, those are concerns as well. And then you just, of course, listen to their lungs, their heart, make sure they lay back and listen to their abdomen, make sure it's soft. If they have any tenderness, generally it's suprapubic. Sometimes, though, they have flank pain, so you want to do a check for that. That's where the no CVA tenderness comes into play. So you want to make sure you thump on their flank areas over their kidneys to see if they have any discomfort there. And then your assessment diagnoses, where you can link your urinalysis to. There are several diagnoses that you can use, whether it's UTI symptoms, acute cystitis with hematuria, or acute cystitis without hematuria. So those are things that you can link for the diagnosis codes. Now, when their urinalysis comes back on the machine, it takes about 30 seconds to run it. As long as they have not taken azo. Now remember, if they've done azo, you have to send it to urine culture. You cannot run a urinalysis. It will be completely inaccurate. So if you look on here, usually the lab tech who runs the urine sample writes down the color and the clarity of the urine. The main things that you're looking for as a nurse practitioner is the leukocytes, nitrites, and hemoglobin. So if you can see that on the left-hand side of the screen, anytime they have leukocytes, those are just white blood cells in the urine. And so some people have a trace amount all the way up to a large amount. Sometimes that can be indicative of a urinary tract infection, possibly. What's more positive for a UTI is if they have positive nitrates. Nitrates, if you look at the eye and nitrates, think infection. That's going to be a little tip that's going to help you be able to diagnose that. So sometimes, on there on this you can see that some of them have been negative and then others have been positive for this grouping of urinalyses. So of course, anytime they have a positive nitrates, always treat with some sort of antibiotic while you're waiting for the urine culture to come back. And then lastly, you can look at the hemoglobin level if they have blood in their urine. So some of these are moderate amount of blood, some are, less, so it just really depends. So those are also kind of some things to look at. Sometimes they have blood because they have irritation at the urethra and it does not necessarily indicate a urinary tract infection. Also, males who have blood in their pee, sometimes that can, again, indicate that they might have a kidney stone kind of issue versus it being a urinary tract infection. Next, several days later, people's urine cultures can come back. As you can see on this particular report, it's showing that it's greater than 100,000 colony count of Citrobacter phenudi. I'm saying that right. Anyway, if you look down at the antibiotic choices that you have to pick from, you have some choices that are listed on the left-hand side for antibiotics, and then you have an interpretation that's listed next to that. And so, of course, anything that says resistant means that you cannot use that particular antibiotic grouping to treat that urinary tract infection, as it will not work. Of course, anything that's susceptible means that it will treat that particular infection. And so for this patient, you could treat with a couple different choices here, whether it's ciprofloxacin as a choice, levofloxacin, macrobid or nitrofurantoin, or Bactrim are kind of some simple choices to pick from for this particular patient. And so you, of course, want to look at their allergy list to see, are they allergic to any of those antibiotics, and then pick which choice you want with that being said. Here's another urinalysis, urine culture that's come back, greater than 100,000 colony count. Again, if you look at the choices, there are less choices based on this particular bacteria that this patient grew. So really the only treatments would be levofloxacin, and then you could choose like a doxycycline because tetracycline is listed as susceptible as well. Certainly you would not want to have to give a patient IV medication for a urinary tract infection unless that's your absolute last resort. Here's another urine culture report showing 50,000 colony count of E. coli. Again, you can see some antibiotics listed on the left side and some sensitivity report. All those S's again means it's susceptible, and that you can give lots of different choices of antibiotics for this particular patient, whether that's a Keflex medication, because all of cephalosporins seem to be covered for this, Cipro, Levaquin, macrobid, again tetracyclines, even Bactrim. So you have a lot of choices for this particular bacteria that they grew in their urine culture. Now, there are some urine cultures, of course, that come back that saying that there's no specific pathogen isolated, growth consistent with urogenital flora, no further testing. So, of course, that means that their urine culture was negative. You can decide if you'd like to discontinue the antibiotic, if you put them on something prophylactically or not. And then just, of course, let the patient know that nothing did grow on there. And if they have further symptoms, they should let you know. Otherwise, some urine cultures grow beta strep group B. We see this commonly on reports. So if they have symptoms, you can treat this. They're not going to show a culture report with a sensitivity report for these because resistant strains to ampicillin, penicillin, other beta-lactams have not been recognized. So simply that means that you can prescribe Keflex, whether it's 500 milligrams twice a day for 7 days, amoxicillin 500 milligrams twice daily for 7 days, or augmentin 875 milligrams dash 125 milligrams twice daily for 7 days if they're having symptoms. So you'd want to pick one of those particular antibiotics to treat that if they're symptomatic. Now again, a lot of people have beta strep group B and they don't have symptoms of that. So some treatments for urinary tract infections, whether or not you want to give them medication prophylactically based on their symptoms before you get the urine culture back. These are some choices that you can pick. So you can, of course, give them macrobid 100 milligrams twice daily for 5 to 7 days. You should think about avoiding the use in 65 and older adults unless you have some significant sensitivity report comes back and it's showing that only macrobid is susceptible to that particular bacteria that they've grown. Then, of course, your options are pretty limited. Or if their allergies limit your choices, there are some individuals who have significant allergy lists to antibiotics, and so macrobid may be your only choice to choose from. Even though they are 65 and older, it can make it really challenging. The reason you avoid it in this patient group is because it doesn't necessarily get down to the kidneys and where you want to treat that infection. Bactrim is used most commonly to treat urinary tract infections. It's typically given twice daily for 5 to 7 days. Coflex is another frequent choice, 500 milligrams twice a day for 7 days. And Cipro, 500 milligrams twice daily for 7 days, is not usually used as often unless you have concerns for pyelonephritis, or again, their allergy list kind of dictates what you can prescribe, and that can make it kind of complicated. But we usually reserve that as a last option. We don't like to give fluoroquinolones unless you absolutely have to. Now, of course, you're going to have those challenging patients that have an allergy to all the medication classes, including sulfas, which can be really complicated to what do you prescribe these particular patients. And so you can just consider giving part of Bactrim DS, which is trimethoprim. It's 100 milligrams twice a day for about 10 days. And so even if they have an allergy to Bactrim DS, because of the sulfa component, you're actually taking that part out and just giving them part of that medication that still can actually treat that urinary tract infection, especially if you see it on their susceptibility report that Bactrim DS is one of those medications. It can also be used to treat urinary tract infections prophylactically. So you can certainly give it 100 milligrams once daily if you need to for those complicated patients, again, who have significant allergy lists, who you're really limited on your choices. Fosfomycin is another medication you could potentially give. It's 3 grams as a kind of like a pill that you give for 1 dose. It can be used with patients with allergies as well. And if you're unable to determine what medicine is appropriate, of course, you can discuss with any of your collaborating physicians or consult with infectious disease, and they can run through the options and choices you have. You may find that your only choice is IV antibiotics. Again, that's really the last resort, and I would certainly consult with infectious disease before you pick that as an option if there's other things that you can do for that patient. Now, some patients get routine UTIs all the time, whether it's after sexual intercourse or they just get UTIs frequently. So you can usually use these medications to treat them prophylactically. Macrobid 100 milligrams once daily, Coflex 250 milligrams once daily, trimethoprim, as I mentioned earlier, is once daily. And then, of course, you can give them Bactrim DS, which again is that combination pill of trimethoprim and the sulfa component once daily. And then certainly you want to educate all your patients at the end of each office visit that they need to drink plenty of water, of course, wipe from front to back for female patients. Make sure they wear cotton-lined underwear. Certainly, if they're having incontinence, they need to make sure they're changing their incontinence pads as soon as they become soiled, whether that's with stool or urine, to again prevent problems with recurrent symptoms of urinary tract infection or preventing urinary tract infections in general. So these are certainly guidelines that you want to follow. Now, some other things to consider is if you did give them a prophylactic antibiotic before the urine culture resulted, And then the urine culture results, and it says that it's resistant to, say, Bactrim that you prescribed. I would encourage you to discontinue, of course, that medication, and then you want to pick something else that's in the susceptibility report that will treat their infection. Again, looking at their allergy list to make sure that they won't have any particular problem with that medication. So just some things to consider.